Thank you everyone for joining our talk series tonight and for spending your evening with us. I would love to introduce our speaker for tonight, Dr. Jeremy Shefner, who is an MD, PhD, and Chair of Neurology and Senior Vice President of the Barrow Neurological Institute. He is also Chief Medical Officer for Clinical Research. He received his PhD in sensory physiology in 1976 and his MD with distinction from Northwestern University Medical School in 1983. After completing residency training at the Harvard Longwood Neurology Training Program, he was a fellow in neuromuscular disease at the Brigham and Women's Hospital from 1988 to 1990. He then joined the faculty at BWH, moved to Upstate Medical University in Syracuse, and became Chair of Neurology there in 2004. In October 2014, Dr. Shefner then moved to the Barrow Neurological Institute. He has been active in designing clinical trials in ALS for many years and co-founded the Northeast ALS Clinical Trials Consortium, or NEALS, in 1996. He was PI for multiple trials in ALS and has been in leadership positions for many other trials. He has developed numerous outcome measures for clinical trials, including motor unit number estimation, quantitative muscle strength testing using handheld dynamometry, and electrical impedance myography, and has explored their utility in both patients and animal models. In 2014, he was also awarded the Sheila Essey Award for ALS Research by the American Academy of Neurology and the ALS Association. Please join me in welcoming our speaker for tonight, Dr. Jeremy Shefner. The floor is yours.
Thank you, Priyanka. I'll share my screen. There we go. Well, hi, everybody. It's really nice to be here. I'm going to talk for a while about something that may seem sort of unsexy at the beginning, which is how do we measure ALS? But this turns out to be really important, and it's important both for when an ALS patient goes to a clinic and needs to have an assessment of how they're doing. But I'm going to be talking specifically about why it's important in clinical trials. I think it's a sort of a truism that outcome measures in clinical trials are sort of the work product of the trial itself. If you don't have a good way of measuring the thing that you want to measure, it doesn't really matter whether the drug or the therapy works very much because you won't be able to figure it out. And so I'll talk about the various ways we've been measuring ALS in clinical trials over the years and some new things that I think will impact clinical trials going forward. So here are my disclosures, both research funding and consulting with a variety of mostly small biotech folks. So outcome measures or trial endpoints really depend on what you're trying to do with the trial. And as you probably all know, trials are roughly divided into phase 1, phase 2, and phase 3 trials. Phase 1 is the initial trial to determine whether a drug is safe, whether it can be administered in a way that makes sense in terms of, the ease of taking it, whether it gets into the part of the body that you want it to. In ALS, it's usually the brain and spinal cord, and whether it actually hits its target. When the drug is designed to do a specific thing, phase 1 studies really start the process of figuring out whether that happens or not. Phase 2 studies occur after safety and tolerability have been demonstrated. And the idea of phase 2 studies is to come up with a treatment regimen or a schedule that makes sense for long-term use. And again, get further assessments of whether the drug goes to where it's supposed to go in the body, hits the target that it's intended to, and actually manipulates that target in a way that is at least potentially useful. Phase 2 studies aren't designed to determine whether a drug works or not for a disease, but they lay the foundation for the phase 3 study, which has as its purpose the really fundamental question of, does the drug work in the way it's supposed to, and should it be approved for use in that disease? And so phase 3 outcome measures have to have a number of very specific attributes. The primary one is that the outcome measure must be what's called clinically relevant. And this is an FDA term, and the definition of a clinically relevant endpoint is an assessment of how a patient feels, functions, or survives. And so survival for fatal diseases can be a critical measurement, and for ALS trials in the 1970s, 1980s, 1990s, survival was the primary outcome measure for many trials. The problem with survival as an endpoint is that even though ALS is a relentlessly progressive disease that may be ultimately fatal, it takes a long time to see a difference between two groups, one of which is treated and one of which isn't. And we really want to get answers much more quickly than that. And so we use functional measures for virtually all of our phase 3 trials. We're also trying to move towards something called surrogate endpoints. A surrogate endpoint is a measurement of a biologic property. It could be a blood measurement, a cerebral spinal fluid measurement, an MRI measurement, an image. It could be an electrophysiologic measurement, but it's something that can be objectively measured and which predicts very accurately that a change in the surrogate will be reflected in the change of a clinically important endpoint. And the surrogate endpoints are used for drug approval in all sorts of diseases. So for example, blood pressure is not clinically relevant in that it doesn't impact directly how you function, but it does indicate your likelihood of a stroke or a heart attack. Viral load in HIV or AIDS doesn't directly impact how somebody feels, but it really directly is directly determinative of whether or not a treatment actually is affecting the virus that it's intended to affect. So those kinds of surrogates have really helped drug approval. Surrogates have to go through a very specific validation process to become approvable endpoints. But there's a kind of approval of a drug called accelerated approval, which can use a surrogate if it's determined that that surrogate is reasonably likely to correlate with a clinical outcome. And we'll talk about this much more when I talk about neurofilament, which was a surrogate outcome that led to the accelerated approval of the antisense oligonucleotide tofersen. There are a few neurologic diseases for which surrogates have been used and which are clearly validated. For example, you determine the size and location of a stroke with an MRI, and changing MRI volumes is certainly a validated surrogate for stroke trials. Multiple sclerosis is a disease of sort of distributed and disseminated lesions throughout the brain, and changing those lesions can be used as a way of determining whether a drug works and should be approved. And as I mentioned, and I'll talk about more in a little bit, neurofilament, which is a blood or CSF marker of degeneration of nerve cells, is emerging as a potential surrogate for ALS and maybe other neurodegenerative diseases as well. It's still true, though, that in most neuroscience fields, especially ALS, we're really using functional measures. So the measure of how a patient functions is what's determining whether a drug works or not. And these are the sort of the historical things that we've done over the last 20 years or so. We're using a rating scale called the ALS Functional Rating Scale Revised, or ALS-FRSR. And I'll spend a significant amount of time talking about that because it's both important and because there's been some controversy about it. It's a rating scale with 12 questions, and it's divided into 4 domains: a bulbar function, or face, tongue, and mouth, fine motor function, gross motor function, and respiratory function. And we know a ton about it because we've used this measure for so long. We know about the rate of decline, and we know that in general, although all parts of the ALS-FRSR decline over time, the main part that declines is actually the fine motor or upper extremity function, which is the most sensitive aspect of the scale. We measure breathing with a measurement called vital capacity, which most of you, I'm sure, are very familiar with. Vital capacity again, we know a lot about it. Overall in ALS, it declines by a very reproducible amount and predictable amount every month, and is clearly important because respiratory function is a real strong predictor of survival in ALS. And we also measured strength, and we, in the last 20 years or so, have used a quantitative strength testing battery using a handheld dynamometer, and many of you have had experience with that as well. I think strength is a critical thing to measure in ALS because ALS is predominantly a disease of increasing weakness. And so getting a handle on that, I think, is critical. Survival, I mentioned briefly, and this is a slide that attempts to show you why survival isn't a great outcome measure at the moment in ALS. So on the left is a survival curve in animals, so with the genetic form of ALS, all of which are all of the animals who have this mutation are destined to get ill and die within a very specific and tight range. And so the dotted lines show the chance of survival over the course of an animal's life. And you can see that the animal begins to become, deaths occur at about 60 days, but by 140 days, all of the animals are dead. In this study, a drug had a modest impact on survival, so that by 160 days or so, the animals treated with this drug, and it doesn't really matter what it was because it didn't work in humans, but that 20-day change in survival was highly statistically significant and easy to measure in a mouse study. And the reason for that is that in this study, every animal reached an endpoint. Every animal died. And so we could determine whether there was a change with pretty excellent precision. On the right is a survival study that actually led to approval of a drug, and this is riluzole. And in the same kind of study, looking at survival over time, and the two lines represent treatment with riluzole versus placebo. And the important thing to see is that even at 18 months, which is at the end of the axis on these slides, on these graphs, the majority of the people in both placebo and treated groups were still alive. And while that's a very good thing for them, it means that they didn't participate in the endpoint in any way. They didn't provide any information in that clinical trial because they started the drug, they finished the drug, and nothing happened to them. The difference between the treated people and the placebo people is where the importance lies. And it turns out that this effect of riluzole, which has led to most people with ALS taking this drug, really was shown by about 30 people. The difference in survival between the two groups was about 30 people at any given time. And even with that, to see a difference, the trial required over 900 participants and over a year's worth of study. So it's an inefficient way of measuring outcomes in ALS. So let's move back to the ALSFRS and talk a little bit about it. Again, I'm sure most of you know about this. It's a 12-question rating scale. The questions are divided into to bulbar function, fine motor movement, gross motor movement, and breathing. And it's very reliable. This is just a slide I grabbed from a clinical trial that I participated in. And this is a single site with patients showing changes over the course of a number of months. And you can see that any given line is following a pretty standard trajectory. And from month to month to month to month, the pattern is pretty clear. So it's reliable and reproducible. It also measures efficacy, measures the effectiveness of a drug pretty well. So these are 3 clinical trials. One is with Edaravone or Radicava, which was approved in 2017. This is the change in the ALSFRS in the study that led to its approval. The red line on the left is the active treatment, the blue is placebo. And that change, which was about 33% over the course of 6 months, was statistically significant. Tofersen is the antisense oligonucleotide that treats patients with SOD1 mutations. And again, you can see that there's a clear difference between the treated patients and the untreated patients. And on the right, there's a drug that unfortunately didn't go to approval, but in this study, over 3 months, there was a more than 20% slowing of progression in the ALSFRS. So what does that mean actually in terms of relationship to other things? And this is more data from the Tofferson study, looking at, again, at the same figure of the ALSFRS, which is the top left. On the bottom left is vital capacity, change in vital capacity. On the top right is strength using a handheld dynamometer. And the point here is that when the ALSFRS changes and shows a difference between groups, it shows about the same amount of difference in vital capacity and strength. So it actually correlates very well with other things that we think are important. And that's been pretty much true for every positive clinical trial we've done. So again, here's the reldesemtiv study, which was a 3-month study again. The ALSFRS change from placebo was 25%. The strength and breathing changes were almost the same. This is the Radicava study. I don't have a graph, but the numbers show that the change in the ALSFRS, the difference between the treated group and the placebo group was about 33%. That was very close to vital capacity. It was close to a functional rating scale, a quality of life scale called the ALS AQ40. So the changes in the ALSFRS very much paralleled other things that we think are important in ALS. And then finally, the AMLEX study showed almost the exact same pattern. That study showed a difference between placebo and treatment of about 25%, which is on the right-hand side. Slow vital capacity, which is at the bottom, which is the respiratory measure, is almost the same, 23%. And both ALSFRS and slow vital capacity changed a bit more than a quantitative strength measurement called ATLAS. So despite the fact that there's been some sort of controversy about how good a measure the ALSFRS is, it actually changes very systematically. And when it shows an effect, the other measures that we gather at the same time almost show very close to the same effects. One other criticism that people have sort of raised about the ALSFRS is that it may not be linear, meaning that the drop over time may not be a straight line. And certainly that is true early in the disease and probably later in the disease. But during the period of time that most people are in clinical trials, it's very linear. And so I grabbed 3 studies where not as a function of what worked or didn't work, but just to show you that the decline in both the placebo group and the treated group almost exactly fall on a straight line. So from the point of view of statistical analysis, it's important if something drops in a linear fashion or not. And the ALSFRS is pretty linear. It's not perfect, however. And here are a number of things that make us want to look for better measures. So the way it's scored is that each item, each question is graded from 0 to 4, with 4 being normal and 0 representing no function. But the differences are not necessarily the same from number to number. And so on the bottom are two questions from the ALSFRS. The first one has to do with how well do you climb stairs? And the difference between a 4 and a 3 is somebody climbing stairs normally or being somewhat slower. That may be important, but it's probably not as important as moving from a 1, which means you can go up the stairs, but you need a handrail, to a 0, which means you can't do it at all. That's a really important change in function, whereas the difference between a 4 and a 3 might not be so important. Similarly, a speech question, which is shown on the right, a 4 is normal, 3 is a minimally detectable difference. So again, maybe very noticeable to someone, but probably not affecting the person's life terribly much. On the other hand, a 2, which is being understandable if you repeat, versus a 1, which means that you really can't be understood unless you use hand gestures, that's probably much more important. And they're both differences in 1. And so just in terms of understanding what the scale shows, it's a limitation that a 1-point difference is perhaps not the same for one part of the scale as for another. Another thing is something that I mentioned briefly, which is that the the different subdomains, bulbar, fine motor, gross motor, and respiratory, don't decline equally over time. And importantly, the subdomain that changes the slowest over time are the respiratory questions. Now, that doesn't mean that respiratory decline isn't critical in ALS, or doesn't have a huge bearing on somebody's life and quality of life. It means that the scale itself isn't very good at measuring it. And so that's a lesion. That's a problem with this scale, because if we had a drug that actually meaningfully affected the respiratory function, we would want to be able to see it, and we want to be able to see it in a very sensitive way. And the fact that the ALSFRS-R can't do that very well is a limitation. Another limitation is that over the last 25 years or so, we've come to realize that thinking can be affected in ALS. It's usually not a major symptom for most people, but if you measure it carefully, you find that at least up to a half of people have some, albeit mild, change in their thinking abilities. And that's important. We want to measure that. We certainly want to know if a drug that's effective has an effect on thinking. And the ALSFRS-R was not intended to ask that question. And then a final, not the last one, but one of the limitations that's important to me is that it's hard to know how much of a change in the ALSFRS-R is actually important. So, for example, I said that the Radicava study showed a 33% change in the rate of decline in the ALSFRS over 6 months. Is that a big deal? Is it a little deal? Is it important? Isn't it important? If you say, well, we expect that a 33% change in ALSFRS should be reflected in a change in survival, then that may be important, but we really don't know. Now, that's not so much a limitation in the scale itself, it's a limitation in the research we've done about it. And so there is a study that's just about to start that's going to ask this very simple question of people with ALS, which is, how important is a change of 1 point over time? How important is a change in 2 points over time? And actually get a measure of what's important to people, so that when we get a clinical trial result, we can know whether this is a meaningful result or just something that's, maybe measurable and maybe statistically important, but may not be functionally important. So that's a limitation that we can actually address. So I want to go back just briefly and talk about survival for a minute, because I mentioned that in general, survival studies take many, many, many hundreds of patients and many, many months to do. Well, it turns out that a couple of recent studies suggest that by looking at survival in different ways, maybe we can do things a little bit faster and get important information about survival in a smaller number of people. So on the left are the survival curves in the AMLEC study, the study that led to the approval of Relyvrio. The gray curve is people on placebo. The blue curves are the people on the AMLEX drug. And now the interesting thing is that the actual placebo-controlled portion of this study is only the period from 0 to 6 months. So that's very much at the beginning, and there wasn't much change in survival at the very beginning. After 6 months, everybody in this study was offered the opportunity to take the active drug, take what is now known as Relyvrio, and almost everybody did. But despite the fact that after 6 months, everybody was on the same thing, there was a clear difference in survival that could be seen many, many months after randomization. And the way this was looked at is that even when people stopped taking the drug or became lost to follow-up, they were still able to find out their survival status, whether someone died and when that happened. And so that was done actually by combing death records, public death records in the various states, and actually identifying everybody's survival status who started in the study, which is something that had never been done before. And so by doing that, one can see that there's actually potentially a pretty significant survival difference between the people who started on the Amylyx drug and the people who started on placebo, even though after 6 months, everybody was taking the same thing. And so that difference is about 5 months in terms of average survival. That's the difference between the 10.0 months, which was the survival on the people who started on placebo, and the nearly 15 months of people who were initially randomized to Amylyx. So that's at least a hint that we can get a view of survival in smaller studies. This is actually somewhat different. So this is a study that was done with Edaravone or Radicava after it was approved. In the Radicava study, mostly because of the way people were recruited, virtually no one died during the 6 months of placebo-controlled treatment. However, once it got approved, there are other ways of gathering data. And so this is data from something called the Optum database. Optum is a health insurance program. And so there are many, many millions of people that are in this Optum database, including people with ALS. And so the investigators here found all the people who had ALS in this database and then looked to see whether prescriptions for Edaravone were being written, and match the people who had the Edaravone the prescription written with those that didn't, according to age, how long they've had the disease, other aspects of severity. And just by looking at survival in those people, which was many hundreds of people, they could see a survival difference, again, on the order of 6 months in the people who were treated with Edaravone versus the people who were not. Now, this is not a placebo-controlled trial, but it's at least a hint that this has a survival impact in addition to an impact on the ALSFRS. I mentioned neurofilament, and one of the things about neurofilament is that at the time of diagnosis, some people have higher levels of neurofilament than others. And it turns out that the higher the amount of neurofilament that you have at that time, the faster you're likely to progress over time. And that's true almost no matter where you measure it, because it turns out these are all graphs of individual patients and their neurofilaments over time. And you can see that in general, individual patients don't really change. If they started out with a pretty low neurofilament level, they stayed low. If they started out with a fast level, with a high level, they stayed high. And so, and this level predicted how fast people were progressing. So that suggests that it's potentially an important indicator of how somebody's going to do. It's also potentially a really important indicator of therapy. So this is a graph that came from the Tofersen study, looking at neurofilament both in the first 28 weeks of the study, which is the placebo-controlled period, and that's the period before that blue vertical line. And the placebo group, their neurofilament didn't change or maybe even increased a little bit over time. The people who were treated with Tofersen, their neurofilament dropped dramatically. And then everybody got put on Tofersen at 28 weeks, and you can see the blue line went down to match the green line, so that everybody's neurofilament matched each other when everybody was treated the same. And so if neurofilament predicts clinical outcome, which at least in this study it did, here's a measure that very sensitively can show an effect potentially pretty quickly. So it could be a very important early marker of effectiveness of a treatment. So neurofilament is a marker not of ALS particularly, but of neurodegeneration in general. So it can be abnormal in a whole host of other diseases besides ALS. But in ALS patients, their levels of neurofilament are higher than healthy controls. And the higher they are, the more aggressive the disease is likely to be. And at least in some diseases, now including ALS, if you reduce neurofilament, it tends to mean that there's an effective treatment, that the progression rate or the disease state is altered. And that's true in multiple sclerosis. It's true in a childhood onset motor neuron disease called spinal muscular atrophy. And it appears to be at least true sometimes in ALS. But it's not always true in ALS. For example, the Amylyx study. that study did measure neurofilament over time and showed no impact whatsoever. But the drugs still work, at least by recording function and survival. So it's not necessarily true that neurofilament can replace these clinical endpoints. It's useful, but it's not. It has to be really looked at in conjunction with other things. So this is what we've been doing so far. Lots of things in the phase 3 toolbox, but ALS-FRS-R has the limitations that we talked about. It would be great to have a measure that changed very early in the disease, or even before people became pre-symptomatic, if we had drugs that actually could work better if they were started earlier. The more sensitive a measure is, the smaller a clinical trial can be, and the shorter duration that it can be as well. And there's been a real movement towards trying to measure outcomes at home. This really got a real boost from the COVID pandemic because people didn't want to leave their house. But it has the potential of reducing the burden of clinical trial participation for people with ALS, for their caregivers, but also for the clinical trial sites for whom right now there are so many drugs to test that there just isn't the manpower to test all of them in an efficient way. And so I'm going to spend the rest of my time talking about some of these home measures, which are primarily digital measures. And as I just mentioned, they have the potential to decrease the burden on sites, to decrease the burden on individual people with ALS. And importantly, they allow for more frequent measurement. And I'll show you why that's important in a minute. There are a couple of different ways that you can think about digital measures. Some of them are things that measure daily movement. So, many of us have a smartwatch. They measure steps. They can measure activity in a whole different way, and they can measure my activity for 24 hours a day. I don't have to have a specific outcome measure that I, sit down and work on at a specific time, and that could be very advantageous. To the extent that these kinds of measures are useful, means that somebody could be in a clinical trial, even though they're hundreds of miles from the study site, if these measurements are reliable and accurate. So I just mentioned briefly that there's a difference between a passive digital measure and an active digital measure. Something like activity or a sleep measurement is a passive measurement. Turns out that Google gathers a lot of data. And one of the pieces of data that it gathers is how fast you can use your trackpad going to one part of your screen to another. So measuring things like that can be potentially invasive and intrusive, but still effective in looking at changes in fine motor function. So those are examples of passive measures, things that can be measured while you go about living your daily life. Active measurements usually involve a specific task or a specific set of tools. So for example, one of the things that we've done is given small spirometers, breathing machines to people with ALS. They cost about 60 or 70 bucks. You can just send it to people's homes and train them on how to use it. And they can perform their own vital capacity measurement. You can actually do your own ALS-FRS-R at home. There's a whole host of others, and I'll talk about some of them. But those are active measurements. They require basically sitting down and doing something specific to assess your disease state. And so this is a study that I did with a colleague named Seward Rutkov a year or so ago, called ALS at Home, where we actually recruited people with ALS completely remotely on the web. We consented them, we trained them on the use of these measures, and then we asked them to basically measure themselves every day for 3 months, and then twice a week for 6 months after that. And the things we asked them to measure were their breathing capacity using a small spirometer that hooked into a smartphone, a hand grip meter, which is in the center. We sent them activity bands and asked them just to wear them. On the bottom left is a probe for something called electrical impedance myography, which I'll talk about a little bit more. We asked them to do their own ALS-FRS-R And we installed an app that assessed their speech on their smartphone and asked them to perform a series of very simple speech tasks every day. And the reason we asked for them to do it so frequently is sort of shown in this cartoon. Now, this is pretend data. It's just magic, but it's the reason why frequent measures might be more effective. So on the left is what you do in a standard clinical trial. No matter what the outcome measure it is, if it changes over time, in this case, it declines. It declines, you can draw a slope through, in this case, these 4 different measurements, or 5 different measurements starting at 0. But there's a lot of variability. And some of that variability could be because the measurement is variable. It could be because people feel better or worse at different days or different times of the day. But if you look at how confident you are of that slope of decline, you're not very confident. Those red lines represent the 95% confidence intervals, or basically how confident you are about that slope. But if you do the same thing and you do it every day, there's still variability. And those 5 points are buried in the noise on the right. But the fact that you're doing it so often reduces actually the variability of the slope itself. And so the slope is the same for both of these situations, but the red line surrounding the line which is the slope is much narrower on the right, meaning that this measure is a way better measure when it's done, when it's assessed frequently than when it's not assessed frequently. And so we looked at this in about 113 patients. I won't belabor exactly the characteristics of the people who did this, although for most natural history studies, people who enroll in these kinds of studies change a little bit more slowly than people who are in clinical trials. And one of the things we asked them to do is this electrical impedance myography test. And this is an electrical test of muscle, but it's completely imperceptible. And so just looking at this photograph, you know that basically there are 4 probes. 2 of the probes inject electrical current into the muscle, and 2 of the probes record it. And again, it's electrical current, but it's at an intensity that is imperceptible. You can't feel it. And you inject sinusoidal current, which are the current at the bottom. And it turns out that healthy muscle transmits electricity in a different way than diseased muscle does. And in ALS, the changes are very consistent over time. And so here's a study where the ALS-FRS-R was measured in a group of people with ALS, as well as these measures of electrical impedance myography, and it paralleled the ALS-FRS-R very well. The bottom part of this curve is actually something called a power analysis. So one way of sort of getting an idea of how good an outcome measure is to ask the question to say, well, okay, if we do a 6-month trial of this measure and it declines it with a certain rate and a certain variability, how many patients would we need to show a significant difference of 20%? And many of the typical outcome measures we use, those numbers are in the many hundreds of patients. But on the right-hand side of this bar graph are the EIM measurements, showing that you need many fewer patients to show this difference when this measure is used. So it's potentially an important outcome measure for clinical trials. And this is the data from a bunch of different measures. And so these are in rows. The first one is electrical impedance myography. The second one is hand grip. The third one is vital capacity. The fourth one is activity using the actigraph. And the last one is the ALS-FRS-R. And this is looking at the decline over time when measures are taken daily, twice a week, once every 2 weeks, and once a month. And the gray bars are showing how the confidence intervals, how much confidence you have in a given slope changes the more frequently you measure it. And if you go from left to right, you can see that those gray bars are getting bigger for every single measure. So it doesn't matter what you measure, the more frequently you measure it, the better off you're going to be. And so this actually has a pretty significant implication for designing clinical trials if you can get people to measure things rapidly. And if something's easy to do, the people in this study were quite willing to do it. I want to give some time for questions, so I'm going to skip these things, go by pretty quickly. This just makes the point that the more frequently you measure something, the greater the power you have to see a difference from a drug. And we asked people what they thought about this, and in general, people thought that doing these things to themselves on a frequent basis actually was a positive experience in virtually all circumstances. So finally, I do want to spend a couple minutes talking about speech. I said that we installed this speech app on people's smartphones. And it turned out that this app actually predicted the ALS-FRSR really well. So this is some of the values that were objectively measured, sort of correlated to the ALS functional rating scale measure of speech, which goes from 0 to 4, which is no speech to normal speech. And the correlation was quite high. More interestingly, these are people who judge themselves to be completely normal with their speech, although they had ALS. And so these are measurements from the speech app. The people with ALS are the green circles, which are, and they're the people who thought they and their caregivers thought their speech was normal. And then the black circles are healthy controls. And you can see that they're different. So even when people think their speech is normal, you can detect abnormalities with this kind of speech application. And you can actually predict when people will lose the ability to use their speech in a useful and viable way. With this speech app, you can, with very high accuracy, you can look at the slope and predict when somebody will lose a useful speech. So I think actually speech has great promise to show subtle abnormalities when you can't measure it, when you can't perceive it, but also to detect a change over time and hopefully an effect of a drug. And for those of you who've been following the ongoings of the platform study, one of the recent results, which is the trial of predopamine in ALS, showed statistically significant impacts of the drug on speech, even when the ALS-FRSR wasn't able to show it. So this kind of a speech measurement can be very important. You can always also use speech to predict breathing. And besides saying that, I think I'll leave it at that. But this shows the correlation between an actual real breathing test and a prediction of breathing from a speech measurement. And you can see the correlation is quite high. And I think I will wrap this up. So I've showed you a number of digital and home-based technologies that can be hopefully very useful in clinical trials going forward. I didn't show you any passive data except for the activity bit data, but passive data can be very important because you can gather data 24 hours a day, and the amount of data can therefore produce very subtle signals, even though the individual variability may be high. Hand movements with typing can be studied. Sleep can be monitored. Basically, much of human behavior can be monitored at home if we take the time to think creatively about it. And I think in many ways, this is going to be the future of clinical trials, and hopefully will make trials less effortful, more sensitive, and will improve our ability to see a signal when there's a signal to be seen. And you know, the number of new drugs that are available to be tested right now is far greater than any time in the past. And so this really optimistic time can only be really the utility of these multiple drugs can only be assessed if we have efficient ways to our trials. So I'll stop there and happy to take questions.
All right. Thank you so much, Dr. Shefner, for that amazing presentation. Like you said, we can jump right into our Q&A section here. So our first question is, how can some biomarkers be validated?
There is a very rigorous validation process that the FDA has established with some input from investigators. It's really hard, and I think the neurofilament data from the tofersen study actually shows that we may not need to do that so much. That what we need is to do studies that show that a given biomarker is reasonably likely to be associated with a clinically important endpoint. And that's done by experiments that are being carried out all the time. And so the more that the scientific community believes that, the more those changes can be used in the future. And accelerated approval, which is basically full approval for a drug, can occur if a marker is reasonably likely to actually be associated with the clinical endpoint. So my guess is that there aren't going to be a lot of validated surrogates in the future, because we're going to be using basically scientific consensus to convince folks of our of the reliability of whatever we're measuring.
All right, perfect. Thank you very much. The next question is, how has the ALS-FRS/R floor effect impacted neuron?
I'm sorry, I didn't get the last part. How is the ALS-FRS/R?
A floor effect impacted neuron.
Oh,
sorry about that.
So yes. So this issue is related to, as you mentioned, the clinical trial of the neuron stem cells that was recently reported. So I don't want to get into specific, right or wrong, but if you actually look at the rate of decline in both placebo group and the treatment group in the neuron study, they're both pretty linear. It is true that study, because of a number of features that were very specific to that study, recruited people who had the disease longer and were sicker than any other recent study. And I think most people who are clinical trialists would say that that's probably not the best group of people to see a treatment effect, even if it's there. So I would say that my message from that study is not so much that the ALS-FRS failed the study, but that the patients that were recruited were less likely to show a clinical effect. So that I think was the problem, more than a specific problem with the ALS-FRS.
Thank you. Our next question is, how often are neurofilament levels checked in ALS patients?
Well, neurofilament is not a standard laboratory measurement like a white cell count or potassium or sodium. So it's still an experimental assay. And so there are some laboratories that now do it at with a very high level of quality and reproducibility. I think in the clinic, they're never checked. But in clinical trials, it's becoming, I think, almost obligatory to look at it. And so I can't think of a clinical trial that's now being performed where neurofilament, either in the blood or in the cerebrospinal fluid, isn't being followed.
All right, perfect. Next question is, how are metrics controlled for age, time since onset, and genetic mutation practical? In other words, are all cases treated the same in statistics, or is there variability?
So that's a great question. There are a bunch of different ways that you try to reduce variability in a clinical trial. One is with your inclusion criteria. And so if you look at the Radicava study and the MLEX study, they recruited a very small subset of people with ALS, people with early disease, with disseminated disease, meaning ALS that's evident in multiple parts of their body, and with disease that was fairly rapidly progressive. And so those studies controlled for those things by recruiting a very limited sample of people. Another way you can do it is by doing what's called covariates, meaning that you look at the data as a function of these different attributes. Disease duration, for example, onset bulbar versus limb onset. All those things, if you use those things as covariates, you can actually sort of account for that variability. Genetic information is a bit different, because clearly if you have a disease, a drug that's intended to impact C9orf72 mutations, it makes no sense to recruit people who don't have that mutation. And so genetic information is being used primarily to in those studies where that's relevant. But in other cases, there's too many mutations to actually look at individual covariates for the different mutations. And so the assumption is that the different mutations don't add that much to the rate of progression. And for the most part, that's true. If you look at the C9orf72 mutations, their rate of progression is very similar to people with sporadic disease. So that's one way to control. The last one that I'll talk about is something called a prediction algorithm, so that there are a couple of groups that have taken all sorts of baseline factors related to ALS and created a model that says, okay, if you have this, 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 and this, I think you're going to progress at this rate. And they're pretty good. They're not necessarily perfect, but they actually, if you use those again as a covariate, you can account for variability and again reduce the size of your clinical trial.
Thank you. Our next question is, in the Edaravone survival slide you showed, the treated versus untreated curves were separated over the first few months, but then stayed parallel to each other. What is the interpretation of the fact that the slopes are the same in treated versus untreated after the first couple months of treatment?
Great pickup. I have no idea. I think what I would say just in general is that that kind of data is really useful to get a hint of what's going on. But remember, that was not a placebo-controlled trials. Nobody was randomized to be in one of those groups versus another. It was a look at people on Edaravone versus people not on Edaravone for whatever reason. And so that can give you hints about things, but I think sort of looking at the details of that kind of pattern probably is asking more of the data than it can actually provide.
Perfect. Next question is, why is the European community not eager to approve ROVREO? In contrast, the FDA provided full approval after only one phase 2 trial.
Well, the EMA definitely has different standards for drug approval than the FDA right now. And with respect to ALS, the EMA is very focused on seeing the behavior of drugs for longer than 6 months. A year is sort of their minimum. And they really want to look at survival data in a placebo-controlled trial. Who's right? Who's wrong? I mean, I strongly believe that in a disease like ALS, where every moment counts, if we have safe agents that have a statistically valid way of being analyzed, we should be approving drugs if we think they work, and then especially if we have ways of reproducing it. Now, it's a very interesting time in ALS because the US approved RELYVRIO, for example, on the basis of this small 6-month trial. And now there's going to be a much bigger, longer trial that's going to report its results in a number of months. If the bigger trial confirms the smaller trial, we'll all breathe a sigh of relief and say, boy, we're on the right track. If it doesn't, then it really calls into question whether we can trust these small, short trials. And the same thing's true not only for RELYVRIO, but for Edaravone. There's a larger placebo-controlled trial of Edaravone in Europe as well. My hope and actual expectation is that these trials will reproduce. But if they don't, it really does call into question the ability to test something definitively with a small sample size and a short duration.
Thank you. We have about 3 questions left. What's the name of the speech app, and is it publicly available?
Well, so there's multiple speech apps, and I don't want to be a an advertisement for specific technology. So I think I'll defer on that, but it's being marketed for clinical trial settings. And there are a number of them. There are at least 4 different apps that I know about. I mean, it's not a secret. The one that I've worked with the most is something called Oral Analytics, which I think is a very high quality tool that can look at multiple attributes of speech, but I don't know that it's any better than the other applications.
Perfect. Next question is, what do you think about imaging as a marker, like MRI/PET in ALS?
Well, they're both expensive. So far, they don't show anything with anything close to the level of sensitivity that even the ALS-FRS has. So I think that it's unlikely they're going to play a large role in big trials in the future. PET is different because it can actually show whether a drug gets to where you want it to go and hits the target you want to hit. And so you can do PET in small studies just to show that your drug is doing what you think it should do. And then you do your larger study with other endpoints. So PET can show answer very specific questions that would be otherwise very difficult to answer. So I think for small selected studies where you have that kind of need for that information, it's likely to be important. But I don't think either of them are going to be phase 3 outcomes.
Thank you. And our last question is regarding variability. This person has said trials want people who are less sick, but there is great variability in time to diagnosis. What is the best route to faster diagnosis?
Boy, that's something that we've wrestled with for as long as I've been interested in ALS. And I don't mean to be a downer at the last question, but I don't think there's an answer to this. And the reason for that is that if you look at the biggest drivers of delay of diagnosis, the biggest one is the time it takes for an individual person to get to the doctor. So, people have a little bit of weakness in a hand or a little bit of weakness in their foot. If it's their hand and they're in their mid-50s or early 60s, they go, geez, maybe I'm getting carpal tunnel syndrome, and you just wait it out for a while. If it's a leg, you think, well, I have back pain. Everybody has back pain. Maybe it's a disc, and you wait it out for a while. You finally make your appointment with your primary care doctor, who kind of thinks the same thing you do, because it turns out that a primary care doctor sees anywhere between 1 and 5 people with ALS in their entire career. So it's not something that they're going to see over and over again. And so they do that. They have the same thought pattern, and maybe they send you to an orthopedic surgeon or another specialist that doesn't really recognize ALS. So, when somebody walks into my office, my conviction is that I'm pretty good at identifying ALS right then and there. But it takes those many months for that person to get to that particular situation. And I don't really know how to fix it. Now, having said that, there probably are ways to identify disease earlier. They're pretty intrusive. For example, everybody has a smart speaker in their house. That thing is listening to everything you say. And so if you had, for example, that speech app loaded on your smart speaker, and you signed up for the health component of that smart speaker, you could say, hey, Jeremy, I've noticed that over the last 2 or 3 weeks, your speech is a little bit different. Maybe you should go ask your doctor to send you to a neurologist. Could that help? Maybe, but it comes with a lot of other social problems that I'm not sure we want to deal with right now.
All right, well, that was our last question. Thank you so much, Dr. Shefner, for an incredible presentation. We have definitely learned a lot, and we appreciate your time and efforts as well.